All right, well, welcome everyone. My name is Risheet Patel. I am the medical director at Freedom Healthworks, and today we're going to talk about direct primary care for students and residents. And we also have Jason Rutz with us. Jason, if you want to introduce yourself briefly.
Yeah, hi everybody.
All right, well, I will take us through the agenda for today. So we are going to start with defining what direct primary care is, explore some of the features and innovations in direct primary care, review some of the common misconceptions that we see, and then we are going to close with some suggestions that we have for residents that are entering the workforce about kind of if they have direct primary care on their mind, how to maybe navigate some of that early career stuff. So just a little bit about myself. I'm a family physician, and when I finished my training, I joined a local hospital network here in a traditional family medicine office. Did that for several years, but started to get the itch to look and say, is there a way that we can provide primary care in a little different format than the traditional fee-for-service insurance-based office? So in 2015, I left and went to a company that does a lot of employer-based clinics, so near-site, on-site clinics, and it was my first taste of how to provide primary care outside of the insurance framework. But ultimately decided I wanted to do this on my own. So in 2017, I opened my own direct primary care office, Fisher's Direct Family Care, and have been working there ever since. And for the last year or so, have been working as the medical director with Freedom Healthworks as well to help other physicians launch and grow their own direct primary care offices. So that's a little bit about me. Jason, if you want to give us a little bit of your background.
Yeah, hi, my name is Jason Rutz. My experience has been kind of on the other end where I started my career after college with United Healthcare on the consumer retail side of health insurance. A little bit different perspective, but my division of United Healthcare we were the epicenter and the originator of medical savings accounts and health savings accounts. So really big on consumer-driven health spend, and over time understood kind of the problems that were happening with healthcare, and it's kind of become out of control. So, being a little bit of a problem solver at heart, this is a great place to start with trying to reinvent healthcare from the bottom up. But with the implementation of the ACA, I left healthcare and I went kind of more in the technology field and software, and then with Freedom Healthworks, came back into healthcare really trying to be a change agent. So my role with Freedom Healthworks right now is really promotion of direct primary care, and I'm really searching for areas of demand where DPC would be a good fit to help try to proliferate it amongst the market. And so that's kind of what I'm doing now.
All right, well, sounds good. So let's take us through a little bit about what direct primary care is. So some of you might be familiar with this, some of you, this might be the first time, but direct primary care is a primary care model where physicians work directly with patients without the influence of insurance companies or third-party payers. So just kind of having that one-on-one connection with your physician and the patient. And for the most part, this care is provided in a membership-based model where most of the primary care services are covered for a fixed cost. So not a lot of individual charges and fee-for-service stuff. So when we look at what that does is, again, it moves us away from that fee-for-service transactional type of medicine and moves us to a more membership and relationship-based model. Sometimes the care in a traditional setting is more fragmented, maybe multiple offices or physicians, where we really try to provide more holistic care where we do as much as possible inside of our direct primary care office. And the care in a traditional office is, well, it's traditional. It's based on insurance codes and billing, really doesn't leave a lot of room for innovation where we try to really change things in our direct primary care offices. And then also we really try to focus on cost savings. So a lot of things that are not only done in the office, but outside of the office, like labs and medications, we really try to focus on how do we save the patient money in those types of things. And we'll talk about that here moving forward. So some of the innovations that we'll touch on here, one is definitely technology. So we use a lot of e-visits, telehealth, mobile communications, different platforms for that. How we actually provide care in the office. So some of you may have heard of group visits, which we'll talk about here briefly. That's something that we definitely do. And then ancillary services as well. So in terms of in-office testing, procedures, maybe different roles for education or counseling, we really can try to bring all that into the office and provide, again, more of that comprehensive care in one setting. So So some of the results, these are some older studies that have been done, but you really see a big reduction in some of the drivers of costs in healthcare. So surgeries, specialty visits, ER visits, hospitalizations, those are really big ticket items that can drive up the cost of healthcare for the patient and their employers. But we really see a huge reduction in that in direct primary care. So overall, we provide high quality care, increasing flexibility, saving time and money, not only for the patient, but for the physician as well. And then again, improving satisfaction all around as well. So I think physicians are a lot happier. Patients definitely love the care they get in a direct primary care setting. What we'll do is we'll kind of go through some of those innovations piece by piece and kind of show you kind of how this actually looks in a day-to-day office setting. So we'll start with just providing care in the office. And Jason, I'm going to tag to you a little bit as well. I know you're a patient in a direct primary care office as well. So first, just starting with in-office appointments, we have longer appointment times. And what you might see there is your typical exam room, but we also spend a lot of time, and this is my office, in a consultation room where we can sit comfortably around a table and have the patient's chart open and really talk about things, whether it's lab results, medications, just kind of lifestyle changes. So it really gives us a lot of flexibility in how we provide that care in the office. Jason, what's your experience with this?
Yeah, so my experience, luckily, I've maintained pretty good health so far. There have been some, a couple of issues that were a little bit perplexing, that minor things that I had to work with my DPC physician on. But the experience is completely different. So whereas in traditional fee-for-service, I would, maybe be limited by the amount of, the appointments that are available. Maybe had to wait, a few weeks even to get an appointment. Obviously, if it's more urgent, they can, always fit you in at the expense of other patients. But it's a very laid-back experience, and typically I'm the only one in there at a time. And there's a lot of conversation that takes place. I've had doctors sit down with me outside of the appointment room, research things as they're talking with me, and really take the time to, I guess, get to the root of the issue. But I guess the greatest aspect of my experience as a patient being with DPC is that the follow-up, the follow-through, if there's any questions that I have. My interaction with my DPC physician is primarily with my smartphone. So I have a great relationship with my doctor. My doctor knows me, knows my situation because he's not handling as many patients. And so, conversations don't need to start from the beginning. They can kind of pick up where they left off before. And so the interactions doesn't necessarily need to be me always going into the office. They could be me at work, just messaging the doctor back and forth and having a quick conversation about something. So again, completely different experience, and it's all positive, much more laid back, much more conversational. Again, I feel like my doctor knows me, and I know my doctor a lot better that way. So I guess from a patient standpoint, it's pretty transformational.
Well, sounds good. Yeah, and we'll talk about some of the technology here in a second. But I think the other thing that we see when you are in the office is, we don't really have to fit your one visit into a particular code or a particular visit type or a diagnosis. A lot of times when I'm with patients, we'll start talking about one thing and easily morph over to something else. And it doesn't really matter because we're not going to be coding or billing that individual visit. So as long as I just keep a record of what we talked about, it really does allow for that very conversational, free-flowing time. And we do have longer appointment times. In our office, most of our visits are between 30 and 60 minutes. So we have plenty of time to address all those options. You had brought up some of that technology piece, and so we do things like e-visits, telehealth, and mobile communications, and so they do kind of mean a little bit different things. So what you see here on the screen is what would be called an e-visit, where maybe you have a structured concern, back pain in this example, and the app that we use will ask you a number of questions, and then we'll get sent the results of that or the answers, and we can then decide the next best steps, whether it's continuing it electronically or potentially saying, hey, this sounds a little bit more serious, maybe we'll call the patient and have them come into the office. So we do have these e-visit capabilities, just mobile communications. So sometimes when patients have questions, I know in a traditional office, they may call the office and talk to a nurse and kind of relay the messages, but we know everybody loves texting. So our app allows messaging back and forth. So you can just kind of text the physician and kind of get a quick answer. Here's one where you can actually, you can send pictures and videos with it. And then also just doing the full-on video visit. So I know everybody's familiar with Skype or FaceTime, and so that's an option as well where we can use an app just to quickly video chat with the patient, save them some time from having to drive to the office or come on in. We can kind of just meet them where they are and get them taken care of. So Jason, sounds like you've used a few of these features in your interactions with your physician.
Yeah, I have.
Okay, well, sounds good. So one other thing that I know as far as providing care in the office is group visits. So this is something that's been studied in the past and have had some levels of success depending on the group that you're with or the system you're with. But basically providing care to a group of people that have a similar need. And the classic example that's always studied is patients with diabetes. And so a lot of times there's a lot of educational piece in learning about diabetes and how to handle your blood sugars and dietary concerns and what all of that means. And so instead of having a one-on-one session with a patient, you can bring a group of people together and talk about all those things in a group fashion. And it's kind of a neat way of, the patients oftentimes they start learning from each other. So they might share a story of, hey, this happened to me and I was able to handle it this way. The issue in a traditional setting has been, how do you pay for these types of visits? Can you use traditional codes? How do you figure out the payment method? And in a direct primary care model, it doesn't really matter because everyone's paying that monthly fee for the office to have that access. As long as we can kind of coordinate that group of people, it really opens up the possibilities of how we can provide that care to patients. So I think group visits is something that we will definitely see expanding in a direct primary care setting. I want to focus on some of the ancillary services as well. So we obviously provide great care in our office, but patients often need things outside of our office. So lab work, imaging, medications, things like that. And so what we were able to do is actually provide a lot of these ancillary services at a wholesale cost. So we will work with providers. So let's say for labs, for example, we've got some lab providers in the area that run the whole gamut of laboratory testing. And we work with them and say, hey, if we can just provide a cash price for these labs, where we'll get this blood drawn, you run the tests, and at the end of the month we'll pay you the monthly bill for what all of these labs cost. What's the reduction in the cost? And so oftentimes we're seeing prices that are 80 or even 90% less than kind of what the retail price is. And for a lot of these providers, when you cut the overhead out in terms of the billing and the insurance coding and hunting down the payment, they're able to provide these labs at a markedly discounted price. So Jason, I know you've worked a little bit with some of these providers and kind of get some of that pricing that we've seen in the market. So what's been kind of some of the examples or experiences that you've seen with this type of arrangements?
Yeah, so because of our mission with Freedom Healthworks is to help doctors thrive within kind of a membership DPC environment, is to use our buying power because we have a few thousand patients. Use our buying power to continue to bring down prices for labs, imaging, bring services that are not normally available to an independent DPC. So there's some things that we do that are unique to our organization that give physicians access to things that they can provide to their patients. So really allow DPC to scale in that regard.
Okay, yeah, so labs and imaging you mentioned. Medications are another thing. So I used to think, especially with the generic medications, that kind of the $4 list at some of the pharmacies was as cheap as you get. And really, we've been able to find pricing through medication wholesalers at even a much cheaper price. And so the regulations vary a little bit from state to state, but in Indiana, for example, we are, as physicians, can dispense medications out of our office. And so we'll work with our patients and figure out what are the medications that you're taking. I usually will price things out with our wholesaler or kind of use GoodRx, for example, might be a coupon service that people have heard of that can provide pharmacy coupons just to figure out what's the cheapest way to get medications. And oftentimes we're saving patients, $10, $20, $30 a month on their medications. And that's a huge savings. And a lot of that sometimes can even go into paying off the membership that they're paying us in the first place. So really kind of a great way of getting value for our patients. Supplies are another thing. So we think about glucometers, nebulizers, braces, splints, those types of things. And we do the same thing where we'll just look at our medication wholesalers. We kind of compare some of these things are available without prescription. So you can just get them on Amazon or any other online service. So we'll kind of compare prices there and just say, how do we get some of these medical supplies for our patients at a reduced cost? And we'll be able to pass that on to our patients. In-office testing, I know sometimes with traditional offices, when you do things like an EKG or a spirometry, there's an additional charge for that. What we do in direct primary care is really try to internalize all of that cost. When we look at something like an EKG, there's not a whole lot of cost to running an EKG. So we kind of include that into the cost of our membership. So if our patients need something, then we will run that test, I'll interpret it, and there's no additional cost to the patient. And it really then opens the doors too to some other neat things. So what you see here on the bottom left, that's something called a cardiomobile. It's actually considered like a one lead EKG, just something where the patient puts a couple fingers on that little pad and you get a little rhythm strip of kind of what's happening with their heart conduction. So little things like that, which in a traditional setting might be difficult to figure out how much am I going to charge for that? What's the code that I'm going to use? In our office, because we don't really do the individual billing, we'll just say if this is something that's valuable for our patients to do that testing, we'll get it and we'll offer it to our patients included in the monthly membership fee. So definitely kind of a neat way of expanding some of the offerings that we have in our office. And then the same thing goes with procedures as well. So I know through our training and as a student and as a resident, we learn to do a lot of procedures, skin biopsies, cryotherapy, GYN procedures. And sometimes you get out in the traditional setting and you can continue to do some, but depending on the number of patients you're seeing and what your office has, you may not be able to continue a lot of those procedures. And they can also then get very pricey for patients. We'll talk about deductibles here in a second, but oftentimes the cost of these procedures is very high just based on if your hospital network has the coding for it. So as you bring those procedures into your direct primary care office, what we really charge is just the cost of supplies. So oftentimes if I'm doing, let's say, a skin biopsy, we might need a scalpel and some suture material and things like that. So we'll just charge the patient the cost of those supplies, and otherwise the procedure would be included in the membership fee to do that. So really brings a great way of just enhancing the value that patients get out of their direct primary care membership. So Jason, anything else you want to add before we move on to some other topics here about your experience being a patient? I think you may have had some of these procedures or things like that done in the past, but anything else that you want to add before we move on?
Well, the other thing from a patient perspective, again, is the value proposition, which we'll talk about in a little bit more. But from a patient perspective, getting those, if I had any procedures done within the office, sometimes they're included, sometimes they're just a nominal fee for the supplies. But really, I don't have to worry about what my expense would be. So the practices themselves are, incredibly high value from a patient perspective. So that's just a kind of tag on to that.
Yeah, and I think the other thing we kind of maybe mentioned, but the other thing is with all of these things, it's really nice to be able to tell the patient upfront what the cost is going to be.
Right.
So I know I was guilty as charged with when I was in my hospital-based practice. Patients would ask, "Oh, how much are these labs going to be, or what's that X-ray going to cost?" And I really had no idea. And oftentimes it would you go to the lab or you go to the X-ray imaging facility, and they didn't know either. It would based on your insurance and what your copay was, and what's your deductible, and so there really is not a lot of transparency in some of that pricing.
Right.
But in direct primary care, because we kind of set these prices all up front, we can tell the patient exactly, here's what the cost is going to be. It's your choice if you want to do it or not. If you're comfortable not doing it, we can hold off. And so it makes it really easy then to make some of those decisions, knowing exactly what the price is going to be. So that makes a very comforting thing there. So let's move on to some of the misconceptions or myths, if we'll call them, about direct primary care, things that we kind of hear on a regular basis that we want to kind of dispel a little bit, and we'll see if we can do that. So the first thing we hear a lot from, not only from students and residents, but also from practicing physicians, that DPC is really just concierge medicine. And that's not accurate. So let's go through some of a illustration here. So if we think of our typical fee-for-service insurance-based office, a concierge medicine physician usually will provide services around that fee-for-service framework. So you may pay a monthly or an annual fee to a concierge doctor, and a lot of times that's really for just the access to that physician. So maybe have a little bit longer appointment times, maybe have some evenings or weekends access. But at the heart of their practice, they're still charging on a fee-for-service basis, where they're still submitting insurance claims and you are still paying copays and you may get bills later. So that is kind of at the heart of what concierge medicine is. Direct primary care, on the other hand, is actually an all-encompassing. So that monthly fee that patients pay to a physician covers everything. So there's no additional insurance billing, no copays, no hidden bills after the fact. So everything is covered together. This is a nice little chart that I found that kind of goes through some of that. So you can see in the concierge column, not only is the price point much higher, but again, there is insurance billing, there may be copays, and there may be some other charges that come with that. Whereas in the direct primary care office, you pay that monthly fee and it pretty much covers all the things that come out of that office. So there's not any additional charges there. So Jason, I know you talked to a lot of potential physicians that are looking at direct primary care. Do you kind of see this misconception a lot?
Yeah, so whenever I explain what DPC is, I would probably say a majority of the time they say, well, so it's like concierge. And concierge is kind of the concierge name is kind of more of a brand element than it is an actual model of care, because you have concierge practices that operate around a fee-for-service framework, and then you have concierge practices that operate within the direct primary care framework, which means totally disconnected from the fee-for-service world. And in that case, the concierge practice and the DPC don't necessarily aren't any different. And it becomes a branding element at that point. Typically, a DPC practice that operates like a concierge practice will see even less patients, so maybe 200 to 300 patients total. The cost per patient goes way up, and they may throw in some other things that are, are extraneous, or spend a lot more money outfitting their practice, provide maybe some additional service elements. But for the most part, DPC and concierge are the same thing. And but it kind of shows you the flexibility of the DPC model, where it really fits for physicians that want to do a variety of different things, and practice styles, I guess, for that matter. So functional medicine or osteopathic or specializations in certain things. The direct primary care model itself is very, very flexible, and that's very attractive to doctors too, because it's almost like you can start from a clean slate and create your practice from the ground up and create your vision for your practice from the ground up. So it doesn't need to fit specifically an existing framework. Operationally it may fit a certain framework, but from a focus, it could be pretty flexible. And then that's a great thing for us, is not one direct primary care practice is alike. They're all very different, or all have different elements that are part of the practice.
Yep, well, that sounds good. So that takes us into our second misconception. So, okay, if we are going to agree that DPC is not just concierge medicine, then it sounds like DPC is just for the affluent or the wealthy, correct? Well, I will say, as somebody that owns and runs my own DPC practice, that can't be farther from the truth. So the first thing is, we have a very large number of uninsured patients that come to our office. So they may be uninsured for whatever reason. They're in between jobs, or they just have chosen not to take health insurance. But for them, coming to a direct primary care office is of great value. So for a fixed monthly fee, and they can put it into their budget, just like a gym membership or their cell phone bill, they kind of know I have essentially unlimited access to a primary care physician. We definitely tell them that, if you have some more major medical issues that require going to the ER or going to the hospitalization, that's not going to be covered under our plan or in our office, and they're aware of that. But for them, instead of having to pay per visit and pay for individual labs and medications and just paying the full retail price, coming to a direct primary care office can really provide great value for those patients. And so we definitely see a very large chunk of patients that find direct primary care offices because of the value that they provide. What about underinsured patients? I don't know if anybody has heard of this term in the past, but what we're seeing is a huge move in the healthcare industry to higher deductible plans. So I put this graph on here. You can see the different colors. The blue bar is from 2003, and then it progressively goes to 2014, which I even know now is still a while back. But you can see back in 2003, 40% of the population had no deductible, and another half of the population had a deductible under $1,000. So there was not a whole lot of out-of-pocket cost when you went to the physician or got things done. You either didn't have deductible, maybe you had a copay, but you weren't paying a lot out of pocket. And what's happened over time, you can see that the deductibles have gotten larger and larger. And so even up to a few years ago, you're seeing 10% or more of patients having over a $3,000 deductible, and I'm guessing that number is a lot higher at this point. And so it's shifting a lot of that cost from the insurance or from the insurance payment to the patient themselves that they're paying when they seek services. So here's just a typical cost comparison. So in the right column is a traditional practice where, let's say, a patient may come into the office a few times a year. Maybe their annual physical is covered at no out-of-pocket cost. But every time they come in, maybe for a medication follow-up or for an acute visit, they're paying the full price of that office visit. If through the year they're getting some lab work, some medications they take on a regular basis, you can kind of see these are just some typical retail prices. And if a patient has a high deductible, then they're going to be paying all of that out of pocket. If we shift over to the DPC model in the left column, you can see, okay, you've got that monthly fee that covers all the office visits and things that happen in the office. And then we're able to save the money. So for the lab work, for medications, again, we're trying to get some of that wholesale pricing, x-rays as well. You can see that overall through the year, that cost comparison really kind of adds up that you're going to be saving money just by going through a DPC office, even if you have insurance, because again, you're not paying the retail prices or those high ticket items. So Jason, I know this is something that you've done work in the past of developing HSAs and looking at some of these high deductible models. Was this kind of an intended consequence, or is this something that you guys envisioned as this was developing, that because of this, patients are actually may seek less care because they're having to pay more of it out of pocket?
Well, that was the original intention of a medical savings account, is for the consumer to be kind of directing their own health spend. The problem with the current fee-for-service world is there's no transparency, so I can't shop around from facility to facility to figure out what the best price or maybe the best care is. All that information basically is behind closed doors, so it makes it really difficult. That's why, direct primary care, as time goes on, from an insurance perspective, as time goes on, we hope that plans start to adapt a little bit more to this type of model, and start integrating more. We're starting to see that in the marketplace today. So, and that's encouraging to us. And I think it could be a big part of healthcare reform, to really build in DPC. It's such a positive model within healthcare right now. Just to kind of go back one slide too. So talking about it, whether or not direct primary care is for the wealthy. If you take a look at kind of the patient composition of our practices, they're going to be from extremely varying socioeconomic backgrounds. And so we'll see people that are uninsured, underinsured. You see presidents and CEOs of companies. The model works. We've seen DPC practices that have worked in extremely rural areas. So a lot of times, and despite despite logic, I guess, direct primary care practices tend to do a little bit better in rural areas. So areas where they can be a big fish in a small pond. So, and that's where a lot of demand is, because there's just not a lot of choice, or maybe access to healthcare, is that DPC can really benefit those smaller communities, 20, 30, 40,000 people communities, even smaller. Again, it's such high value. A lot of times, unfortunately, people forgo health insurance to go for a DPC membership. Ultimately, we want all to be affordable and work together as a package, and we're kind of working towards that goal now.
Yeah, and that kind of segues a little bit into our next couple slides, which talks about employers. So we're starting to see employers look at direct primary care as a way to help reduce costs. So a lot of large companies, they have typically had a very self-insured insurance plan. So they may have a company that administers it, like Anthem or United Healthcare, but they're essentially paying all the bills themselves. And when you have thousands of employees, you can offset that risk. But even they were looking at ways of reducing costs. So they introduced the health savings account contributions, which, as Jason has said, would hopefully help the patients be a little bit more selective. But what we found is a lot of times with HSAs, patients just didn't go get care because of that, not knowing what the cost was, not really knowing how to comparison shop. They really said, well, we're just not going to go. So what they basically found is, if we actually put in that direct primary care membership layer on top of this as well, and say, you know what, for all of your primary care services, we're going to bundle it together. Here's the physicians you can go see, no cost to you. It really helps them utilize more of those primary care services, and that hopefully will help patients be healthier, help reduce the downstream spends we talked about in the beginning of when you have more access to primary care, and this is not news, that you're going to actually have lower hospitalizations, lower surgeries, lower specialty visits because you have more primary care up front. So I think large employers, this has been happening for a while. What we're starting to see, though, is how do you actually translate this into small companies? So when you're a smaller company, let's say 20 or 50 employees, you don't have that volume to be able to share that risk. So at the heart of this, you may still have a catastrophic insurance plan that, in case one of your employees has cancer or is in a bad accident, you're not bankrupting the company, but you may have a self-insured primary care plan. That is kind of where the company can really be a little bit more flexible and saying, if we can get some of this primary care spend to help, that will help reduce our costs. So you could then maybe layer an HSA and a DPC membership on top of this. And it really provides a package for a small company to say, we're going to be a little innovative. We're going to try to get our patients into a direct primary care office and try to get them better primary care access. And hopefully that will then help reduce some of our downstream costs in bringing that in. So Jason, I know this is something you work with a lot. Have you started to see this model flourish with smaller companies moving forward?
Well, yes. I mean, the answer is yes. And it kind of comes with as more alternatives to traditional insurance kind of pop up, and that could be health shares or things like that. Health shares kind of started with individuals. Now they're starting to branch out into groups, small groups. And the difference is health shares have a little bit more flexibility and can integrate DPC a little bit better. From a larger employer standpoint, I mean, DPC is a cost saving or a cost containment measure. You know, a group implementing a DPC practice or multiple practices to their employees and giving them, you know, access to a DPC physician, you're not going to see just dramatic reduces in expenses, but what you're going to see over time is that you know, the instances of chronic health conditions will be lower. You know, there may be some reduction in ER visits and things like that, and so it becomes a cost containment measure over time, and it will reduce costs year over year too. I mean, not dramatically, but it will reduce costs, whether it's 5 to 10% right off the bat, and then over time will help contain those costs. It's all because of access, and more importantly, I think it's the relationship between patient and doctor. I think that drives a lot of the cost reduction too.
Yep. So I think hopefully that as that picks up, this becomes more of a mainstream option for patients that are employed with their employers. So we'll kind of watch that. So the other area that we want to talk about, you know, in terms of our access to direct primary care is with our patients that are getting care through government models, through Medicaid and Medicare. There are a number of demonstration projects out there currently that are demonstrating the value of direct primary care in both these populations. We're still in that phase where we're gathering data and looking at the feasibility of this, but I can see a time where we might start having programs where patients are instead of kind of out in the world in the fee-for-service model, are assigned to a direct primary care office and have, you know, all of their care provided in one setting from a flat monthly fee, and that can really, again, open up the doors. These are some really vulnerable populations that need a lot of care, and if we can provide high value primary care for them, I think they can be well served and can save money. So that's the kind of goal as well, to help make these financially viable moving forward. So keep an eye on this. This, I think, is a big area where we're going to see some movement moving forward. All right, so the last myth or misconception that we hear about a lot, and this is the one where I think there's some argument, some debate about this, we'll talk about this in a few different facets, is that direct primary care is going to worsen our primary care physician shortage. So when you look at it on the surface, this can be a concern. So a traditional provider of a family medicine, internal medicine, pediatrics, you know, they may have 2,000 to 3,000 patients in a panel. And when you look at a typical DPC provider, they're looking at it around 600 to 800 patients. So on the surface, you're absolutely right. This looks dramatic, and if every primary care physician switched to DPC, we'd have a problem. I'm going to address this in a couple different facets. So one is from the demand side of how many patients should a physician really be seeing or being taken care of. And then I'll also look on the supply side as well of what's happening to the number of physicians that we have that are taking care of patients. So this number, 2,000 to 3,000 patients for a typical primary care provider, it can be calculated in a number of ways. You can kind of say, if I have X number of patients, and if I assume that about 1% of my patients are going to need my services on a given day, how many spots can I have? So if I have 2,000 patients, can I take care of 20 people a day? Then maybe that's my panel size. Or you could do it by the math. If I have this population of patients and they come in on an average of 2.5 times a year, and I've got this many days that I'm open, this many office spots, you know, how many patients can I take care of? That's a very mathematical way of looking at it, but doesn't kind of hit the picture of how much care are you actually providing to these patients, and how effective are you at taking care of their health problems. So what I want to look at is a model from another industry that I think has taken great strides at making sure that they are providing care in a safe manner, and that's the airline industry. So when we look at fatal airline accidents per year, this starts back at 1946 all the way to 2017. You can see there's been a fairly steady reduction in the number of fatal accidents every year. And this is actually looks even better when you look at there are way more airline flights now than there were in the past. So this is back from 1977 to 2017, but just a dramatic reduction in how many airline accidents we've had per 1 million flights. And there's a number of reasons for that. So there's definitely better technology, we have better training, but I think some of the crux of it is we have better working conditions and better air traffic control, some coordination of care. And so I think they've taken a look and said, there's really only so much one person can physically do, and we don't want to make sure that we want to make sure that we don't overtax them. So there's strict rules now with pilots of how long can they fly for before needing a break, how long of a break must they have before they can fly again. And it's really come down to we are really trying to find the best way to keep everything safe. And so this is where we look at physicians as well and say, if we had a busy primary care office of 3,000 patients, are we providing the best care to those patients? And so that could be a little bit of a philosophical debate, but that is something we definitely need to think about of how do we make sure that our physicians and our patients stay safe. The other thing is when we look at direct primary care, I think it's very much in its infancy. So if we had a panel of 600 to 800 patients, that's where we are now. But as we are learning about direct primary care and really enhancing how we provide care to our patients, I think we have room to grow those panel sizes. And this is an example. So I think some of you may have seen this in the past, our patient-centered medical home model, where you really kind of incorporate a number of providers into the office, all taking care of the patients. That could be a health coach, a nurse, a pharmacist, really working as a team to help take care of patients. And this is great in theory. The problem was in a fee-for-service or an insurance-based model, it's really hard to pay for all these people. So are there enough billing codes, or who's paying for these? Is it going to be the insurance company? Is it going to be the physician office? Really got a little dicey of how do we provide this care? But again, in that membership-based model where let's say you just have a monthly fee that covers all the care, you can then start to incorporate some of these other providers into your practice. And that may then help you grow how many patients you can take care of as one physician. If we were able to say, I can help manage medications, but maybe we have a pharmacist on board that can help me do that. Or maybe we have a health coach that can help me take care of some of the lifestyle modifications or helping the patient with weight loss. That will help you as a physician take care of more people. So I think over time, we're going to see that these direct primary care physicians are going to be able to see more people and help really provide meaningful care to larger populations as we continue to evolve and learn from this model. And the other thing I'm going to look at then is the supply side of physicians. I think when we look at direct primary care, I think it's really bringing in more physicians into the primary care realm than we may think. So a couple examples that we've seen directly. One are physicians that are nearing retirement. So, with all the changes in healthcare, the EHRs, the administrative burden, a lot of physicians are saying, I was going to retire in 5 years, but I think I'm just going to retire now. What we're seeing is if we can convert those physicians to a direct primary care model, yes, maybe they're seeing fewer patients than they were seeing before, but if they're going to practice for another 5 or 10 years, we're starting to see that amount of primary care has been salvaged, if you will, for the marketplace. We're seeing great interest from undergrad and medical students and residents, and you guys are on this webinar today learning about that. So we've seen that this is a way of really showing the invigoration of primary care and showing it in a new light. Physicians that are changing careers. So we have a lot of family physicians that may leave their training and go on to maybe do emergency medicine, urgent care, hospitalist work, and maybe at some point they want to move back to just general office-based primary care. In a traditional setting, that can be kind of a daunting process, really learning about all the insurance codes and the administrative burden and prior authorizations and all that can really kind of say, well, maybe I'll just stick with urgent care. It's easy enough. But doing it in a direct primary care model can really simplify that and allow those physicians who want to come back to just office-based primary care to do that in a simple fashion. And then the same thing with part-time providers. We have a lot of providers who, for whatever reason, may just want to work a few days a week. Working in a big hospital system or a physician group sometimes can be challenging as a part-time because you are expected to have just as much as a share in the overhead as any of the other physicians. And so either you're going to be taxed from the number of hours or patients that you see, or your salary might be very low. And so direct primary care really provides you a way to craft the practice the way you want to in a part-time fashion and still have the benefits of the value that you bring to your patients and the revenue that you get, and sharing, balancing that with the time that you want to spend in this practice. So Jason, I know you work with a lot of physicians that we've worked with here at Freedom Healthworks and have talked to a number. Do you see physicians in these categories that are looking at ways of kind of getting back into primary care or staying in primary care?
Yeah, I mean, all the above. For some, they brink on they were on the brink of retirement and see this as a viable model for them to continue practicing. Physicians that are burnout, going part-time, get a lot of interest from new physicians too. So again, DPC is pretty universal. It seems to work for anybody, no matter what their current practice situation is.
Yep, and I think you hit something on the head there. When we look at some of the drivers of kind of our old system, our current system, these definitely do lead to burnout. And that's another thing that we see physicians that maybe not even picking career paths, but are just leaving medicine altogether because of burnout. And if this is a way that we can kind of salvage them and kind of allow them to have a fulfilling career moving forward, I think this is something we definitely need to expand and look at. So that's something that we need to focus as well. So again, on the surface, are we going to have a primary care physician shortage? I don't think so. And there are definitely reasons why I think this might actually be beneficial for primary care in the long term. But time will tell as we kind of continue this model as it evolves, how this is going to fit in the bigger healthcare picture. So our last little topic today are for some of the residents that might be listening to this webinar. We get a lot of interest from residents that are graduating soon and wanting to go into direct primary care. And everyone's got kind of financial burdens as well, from student loans to practice startup costs, those types of things. And I think the easy answer oftentimes is to go and just get an employed position with a hospital group or a physician network. And I think there's nothing wrong with that. I think that's definitely a viable option in an early career. But for those residents that are really thinking about direct primary care, there are things that you can think of when you go and get that first job to say, let me, in the back of my mind, keep thinking that I might want to do direct primary care, and how can I structure my early career to help me set up for a move to direct primary care after a few years. So here's a few things to think about. So first is the contract itself. So a lot of times when you sign with a hospital group or a physician group, you're going to have a contract, and that will have a certain time frame. In the contract will be certain clauses that will give you the direction of, if I want to leave, how much time do I have to give them? What's the notice? What are the stipulations around that? So this is really where you want to spend some time looking at what that means. To say, for example, if I sign this contract, I can't leave before 2 years or 3 years, or when I am ready to leave, I need to give them 6 months notice or a 1 year notice, or what are these basics in there? So really thinking about that, if I want to say, maybe I want to stick with this employed position for a few years and then want to leave and maybe transition into direct primary care of my own, make sure that contract is somewhat friendly to be able to do that. And some of these terms might be negotiable when you're working with your employer to kind of figure out kind of how that works together. The second couple things kind of go hand in hand. So a lot of these contracts will have a non-compete clause. And so they may say, if you leave this employed position for a time of 1 year or 2 years, you can't practice within a certain geographic radius around your old office. And so that's fairly common now. I think there's some talk about doing away with non-compete clauses, whether it's legislatively or actually challenge them in court. We'll see about that. But in the meantime, one thing you can think about is, if there's a place that you want to set up a direct primary care office, think about, if you were to get an employed position, think about how close is it to that geographic place that you want to open a direct primary care office? What's the non-compete clause like? And really kind of think about, how do you structure that currently, so that way when you are ready to switch to a direct primary care model, you're able to do that without being able to be locked out, or without having to take time off to let your non-compete expire. So that's something to think about as you're kind of setting up your employed position, of ways of doing that. The other thing that oftentimes comes with a new contract is a signing bonus, or it could be a loan forgiveness amount. And oftentimes those come with stipulations of, hey, we're going to give you X amount of dollars as a signing bonus up front, but that means you must stay with us for 5 years or whatever the time frame may be. So think about that. And that doesn't necessarily mean you shouldn't take the signing bonus, but look at the clauses in the contract and say, if I were to leave early, if I really realize that I'm ready to move to direct primary care, but this time frame hasn't expired yet, do I need to give some of that signing bonus money back? And maybe you set that aside or save that somehow, so it gives you a little bit of flexibility to say, if I went ahead and spent all of the money in my signing bonus, then I might be burdened to have to pay that back. But if I set it aside and said, this is great money to have, I'm going to invest it or put it in a savings account or whatever it is, when the time comes, if I do need to give that money back, it's here ready to go, and I've not wasted that money away. So something to think about there. And the last thing that we see a lot of is student loans. So I know a lot of people think about the Public Service Loan Forgiveness Program, and they may end up working for a not-for-profit or a charitable organization. What we've seen early on with public service loan forgiveness is that it's kind of tricky to get approved, and a lot of people are not getting it. And so I would not let this be the only reason that you stay in an employed position. If you are thinking about direct primary care, there are a number of other things that you can do with your loans. You can refinance them. There are other ways of getting some of them paid back. And so think about, don't let this be the only thing. And you know, there are a lot of people that we can give advice on, or you can obviously contact us about this. But there's things that can be done to help get those student loans under control before switching to a direct primary care setting. So something to think about. So this is just things that as we work with residents and we talk with them, a lot of them do go in and get employed jobs just from a financial security standpoint and getting some of the money paid back. But here's things that you can think about as you're getting ready to leave for a direct primary care setting, if that's something that you're thinking about. Jason, have you come across residents or talked with them and had some of these issues come up?
Well, probably the biggest one that's come up, and it's not necessarily amongst residents, but it could be young doctors as well as the non-compete and the geographic elements with it. Sometimes they're a little bit hard to navigate. So, you know, I know a lot of, you know, I know quite a few doctors that have, you know, negotiated their own terms, their own contracts, perhaps even eliminating the geographic clauses where, you know, they can move to DPC. It's a tough thing to navigate sometimes. So just, you know, keep that in mind.
Yep. So I think we're obviously here to help. So that's about all we have currently. I'm sure there's a lot of questions, but in our current format, we can't take live questions. But if you do have anything, our email addresses are up here on the screen. We're happy to help. If you're a medical student thinking about direct primary care or any primary care field, I'm happy to talk with you. If you're a resident thinking about direct primary care as a field, feel free to reach out. Jason's talked with a lot of residents and young physicians as well about kind of how do we transition or how do you plan for a direct primary care setting. So we're happy to help with that as well. So Jason, any other closing thoughts that you have or comments you want to talk about direct primary care in general?
Yeah, I think if you're interested in learning more about direct primary care and kind of the role that Freedom Healthworks takes in helping physicians transition to this model, you know, feel free to contact me. But we also, if you go to YouTube and search for Freedom Healthworks YouTube channel, you'll find a lot of really good content there. We've done webinars that we've really gotten in depth about kind of what we do and how we do it and why we do it. And so if you're interested in learning more, you know, in addition to videos of physicians talking about their practice and their love of DPC, and then from a patient perspective too, you can kind of see that a little bit further. So the Freedom Healthworks channel on YouTube is a good resource for you too.
Okay, well, sounds good. Well, I think that's about all we have for today. So we're going to sign off. But again, feel free to reach out to either of us through email or through our website and get more content that way. And we really hope that you guys have enjoyed this. And we really think direct primary care for those going into primary care is a great model to consider and think about. So we hopefully you will look into that and go from there. All right. Thank you guys very much. Have a good rest of the day.